let's talk about because you mentioned the trial, Matt Katz from MD Anderson, part of the Alliance. It was a cooperative group trial that was presented at ASCO. They took 22 patients, they gave them FOLFIRINOX, some got some radiation, about 14 patients went to surgery. Most of those patients had portal vein involvement, not retraction of the tumor from artery. So you got to distinguish, when you're talking about borderline, you got to distinguish the portal vein and the arteries, and that's really where the benefit was seen. Now, getting back to response rate with nab-paclitaxel gem is also high. It's in the 29%. You got to remember the methodologies between the ACCORD trial and the MPACT trial were different. So I think it's reasonable to use nab-paclitaxel gem in that borderline population, but I think most people are using FOLFIRINOX. The other point is—
George, can I interrupt just for that? Surgeons don't have biases usually, but they have this bias about FOLFIRINOX. When they send a patient to you, they say use FOLFIRINOX. I don't know how they got to that conclusion.
Because they talk about it at their meetings.
At their meetings, thank you. So basically, a lot of times the oncologists are pushed to use FOLFIRINOX because the surgeon says, I had a couple of patients who came from Johns Hopkins because they're Michigan patients to have treatment with me, and the surgeon told them, make sure Dr. Philip gives you FOLFIRINOX.
Yeah, but if you get a patient sick, right, you give them FOLFIRINOX and they don't do well, and they are no longer a surgical candidate.
Blame the surgeon.
The surgeons aren't going to be happy with that either. Okay, so you got to take it with both ways. So
I'm not defending the FOLFIRINOX. I'm just saying that's a factor.
And then to comment about the trials that are out there, I agree with you, Philip, that post-op treatment is still the standard. The trials that are out there are nab-paclitaxel gem, okay, APAC, and then the French are using FOLFIRINOX in the adjuvant setting. They are having a lot of trouble giving FOLFIRINOX. They had to get rid of the bolus. They had to bring the irinotecan down by 20%. So it's going to be interesting to see which of those two regimens is most appropriate in the post-resection setting.
But the problem, can I interrupt you for a second? The problem of giving treatments that are toxic, more than average toxic, is that they compromise the delivery of the drugs, and patients end up getting lesser systemic treatment.
Exactly.
That's my concern.
Yeah.
Can I just continue for a second? I saw a patient, an engineer in our area who came for a second opinion. He's like in his mid-50s, and he had T3N0, and he went to his oncologist, and the oncologist in the community wanted to give him an option of either gem or FOLFIRINOX. No gem, nab-paclitaxel, one or the other. And I think it's possible that the nab-paclitaxel in the adjuvant setting would be an insurance issue. Maybe that's why it was deleted. That might be the reason. I'm not sure. And then he came to me for opinion. I said gem. That's the standard of care. And then he sent me an email. He said, I'm very much into science, statistics. My statistics are better with FOLFIRINOX. I'm just going to go back to FOLFIRINOX with that doctor. Now, where he got his evidence, I don't know. But he was extrapolating from the metastatic disease. He probably read the English Journal paper. But again, one thing advised to people who want to give FOLFIRINOX in the adjuvant setting out of protocol is that we tried it, FOLFIRI colon cancer, didn't work.
Oh, I completely agree with you.
Combination with bevacizumab in colon cancer,
right.
EGFR blocker, ECF in gastric cancer, everything fell on.
It is inappropriate to extrapolate data from the metastatic setting to the adjuvant setting. We know that it doesn't work. As appealing intellectually as that would be, it doesn't translate into good practice, and we know that from many trials. I think the neoadjuvant setting is qualitatively different from the adjuvant setting for the reasons that you enumerated. Patients are really beaten up after a Whipple. They are not able to get the same degree of treatment that they can preoperatively, and that's why I think preoperative treatment really is very appealing. And I'm glad that we are devoting more of our resources to studying the neoadjuvant setting.
So outside of trial, both of y'all are given gemcitabine adjuvantly, single agent?
Yes.
You mean adjuvant?
Yeah.
Yeah, I'm giving gemcitabine. One has to keep in mind something which Caio brought up. If you give capecitabine, it's also correct. Because the studies haven't shown really that gemcitabine is better than fluoropyrimidines.
That's right.
It's just easier, ironically, it's easier to use. But certainly, gemcitabine has become our standard, and we use it for clinical trials, control arms, etc. But the reality is that fluoropyrimidines are as good as gemcitabine.
George?
I
know some's
you
coming.
know, when I was at Mayo, we gave FOLFIRINOX, we gave Gemabraxine in the adjuvant setting. So we've done it before. You know, it's like the patient you described. You know, I had a judge who went through the data, and he was very good. He went through the data, and he said, this is what I want. And it gets back to the earlier discussion. What does the patient want? You know, we think we know. We think we know that these drugs are going to fail in the adjuvant setting. But then why are we doing the trials if we think they're going to fail in the adjuvant setting? Because we don't know. We're waiting for the trials to read out, the Abraxane trial, the FOLFIRINOX trial, and these may be advances. So to dismiss them, I don't know. I think then why are we bothering with all these big trials? We're doing them because we want to advance the science. We want to advance the field. And let's face it, Gem is not the greatest drug, okay? And I'm not going to give them Gemerlotinib. So what are you going to do? If they have lymph, you know they're going to come back. They have lymph node positive disease. They have some tumor that makes you nervous. What are you going to do? You're really going to just stick to Gem right now when we know that the FDA approved these trials. These trials are ongoing. I think they're already accrued. So, and the RTOG is doing the trial, the adjuvant trial, and they're bringing in other chemotherapies like Gemabraxine, right? So I think there's some precedent to do that. But I think also I agree with you, you got to be careful, and you want to make sure the patient is a partner in making that decision.
But again, this is an interesting statement. I mean, if a patient comes to me and says, I want FOLFIRINOX, and I have to say, I don't have data, and in this case, his wife said, well, if you don't have data, doesn't mean it does not work. So are we going to start thinking that way? Because, you know, we don't do that.
So what are you going to tell the RTOG when they want to use Gemabraxine?
But they're doing it as part of a clinical trial.
Right. I think that is the huge distinction. To bring a clinical trial experimental arm into your practice as off of protocol, I wouldn't do it. You run the risk of harming the patient, and
that's right.
And it just doesn't. To me, it's as much as we think that Gem is not a great adjuvant therapy. Abraxane could be worse. FOLFIRINOX could be worse, and then you would really be doing the patient a disservice.
Incredible controversy in a setting where limited treatment options, very difficult disease, and I think the answer is going to be in the clinical trials. But let's think about